Bismillahir Rahmanir Rahim. Assalamu alaikum. I am Professor Adam Ahmad Adam. This mycology lecture in systemic mycosis is composed of two topics: Pneumocystis carinii pneumonia and blastomycosis. We start first with Pneumocystis carinii pneumonia. It is caused by the fungus Pneumocystis carinii or Pneumocystis girovosii. This fungus is unlike fungi because it has a cystic stage and a trophozoic stage. Also, it does not grow in culture media. And moreover, the disease that it causes is treated by an antibiotic which is cotrimoxazole. But molecular studies proved it to be a fungus. The infection takes place by inhalation of the cyst. And important to mention here that there is no known environmental source for the fungus. The fungus causes foamy exudate in the lung that blocks the air exchange spaces. And also important to mention that this disease is infectious. The disease will lead to pneumonia with non-productive cough. That is to say, the patient coughs without producing sputum. There will be exertional dyspnea. Dyspnea means breathlessness, shortness in the breath, and that is breathlessness on effort. Then the condition progresses to be dyspnea at rest. Also, the patient complains of fever. Radiologically, the lung shows bilateral interstitial infiltrates. The patient will be hypoxic due to the blockage of the air exchange spaces. Diagnosis: clinical, the laboratory, the specimen to be collected, specimens to be collected, sputum, bronchoalveolar lavage. By bronchoalveolar lavage, we mean washing the bronchioles and the alveoli with normal saline, and then you suck that washing and you deposit after centrifugation to examine the deposit for the fungus. You see here on your left hand side, this is Giemsa stain. Giemsa stain is a stain which is commonly used in parasitology, and also it stains some other microorganism. Here the arrows are pointing to the trophozoid stages. Also, to see the cyst, you stain with Gomori methanamine silver stain to see the cyst. You see here there are multiple cysts and the arrows are pointing to some of them. Treatment by cotrimoxazole. The second topic, blastomycosis. This mycosis is caused by the dimorphic fungus Blastomyces dermatitidis. The infection takes place by inhalation of spores in damp soil and decaying dead plants. The clinical types: acute pulmonary, chronic pulmonary, bone involvement, skin involvement, central nervous system involvement, and genitourinary system involvement. Diagnosis: clinical, then the laboratory. investigations. You collect the sputum, bronchoalveolar lavage, urine, CSF, bone marrow aspirate, skin biopsy. Then for some of them, you can add potassium hydroxide to remove the debris, and you see the refractile cell wall. You see here, the arrows are pointing to the refractile cell wall. Then you culture in subrod medium, and the specimen that you take can be processed histologically to see the changes. Treatment: systemic antifungals like itraconazole, ketoconazole, and amphotericin B. By this, the lecture is over. I hope that it is understandable, and I wish you all the best.